Sorry, my fault. Dang. Come on, baby. Go, go,
Looks
go,
like
go.
it's live on mine. I think it's live.
Okay.
How's it going, guys? I'm Dr. Chris Riedel here with Kirk Vidrine and Claire Kantrow. Did I pronounce it right?
Yes, you did.
Yeah, awesome. Look at me. So we're here to just have a nice little fun chit chat about fasting, inflammation, and pain. Kind of a lot of topics, but a lot of these kind of interrelate. So hopefully we'll be able to go back and forth on these topics. But first off, I think what we're going to talk about today, guys, is fasting, right? So one of the things with fasting is you have a lot of give and take. You have a lot of people talking about all sorts of things. You've got intermittent fasting, you have ketogenic diet where people are talking about it, creating a fasting state. You have just straight fasts. So I just want to know, Kirk, like we'll start with you because I think fasting is kind of one of the things that you research a lot. What would you say, what's your opinion of just like generic intermittent fasting? Because I think there's a lot of leeway in their different types. So I was wondering if you could kind of summarize all the different types of fasting.
Well, so basic fasting, it's got its roots back into long through human culture, from religion to that sort of stuff. But the first medical types of fasting happened about 105 years ago. It's the first time they had qualified doing some type of a fast to help people out for their health or weight loss. And they've seen a lot of different ones. It's pretty crazy. But in general, you only have a couple basic types. The first type is what they call a water fast. It's where you have zero food for either a full day or an extended period of time. The longest one on record was 384 days. A guy was medically monitored and given supplements for vitamins and minerals to keep him alive. Obviously, you can't not eat for that long. He was morbidly obese, but he lost weight into a healthy weight. He lost over 265 pounds in almost a little over a year. So that's a water only fasting. That's no food whatsoever for an extended period of time, usually for just a few days because it can be very dangerous. Then they have intermittent fasting, which is where you either skip food for either the typical versions are 1 day without food, 1 day with food, or they have what's called the 5-2, which is 5 days eating and 2 days not eating. Or you have like restricting your food to a certain time of day, either in the morning, in the evening, for usually around 8 hours, somewhere 12 or 16. But it's restricting food consumption in some way during the day. So when you talk about breaking down fasting, you usually go to either just straight fasting, which is food free, or intermittent fasting, which is, it's supposed to be defined as just what you're closing the gap in the day and only eating during the day. But a lot of people use it interchangeably with alternating days, 1 day on and 1 day off. And that's the broad categories of fasting. Now, the question being whether or not they're effective or useful. I think that's probably where you're going next, right?
Yeah, so let's roll. Which is your favorite?
Oh, I think so the one I want to definitely talk about is called the fasting mimicking diet. That's actually the one I'm trying out right now, and is the one that is promoted by the most famous researcher in longevity in the world currently. He's a professor at USC and over in Italy. So I'd say that's my favorite. But before you can get into that one, because that's not a truly fasting, I think you have to give a little bit of the history of why people are so excited about fasting. And it comes back down to something called calorie restriction, or a calorie restriction diet. So what we've known for somewhat almost 80 years now is that if you give organisms, things from just bacteria all the way up to research monkeys, if you give them enough micronutrients, vitamins and minerals and that sort of stuff, but you restrict the total calorie level by anywhere from 20 to 50%, these organisms, all of them, live longer. Now, it varies on how much longer they live, but they live significantly longer, and it seems to extend life and extend health and have a bunch of other benefits. It's so huge, and the response is so big that some people have related to adding years and years and years to human life, and many people have researched it as a way to possibly like affect diabetes or various different maladies that humans go through. And in particular, people believe the reason it's really hot right now is because people believe that it'll cause more body fat loss than a normal calorie restricted diet will. And that's because some of the earlier research showed in particular that that happened, particularly in animal subjects. But even in human subjects, not only did they lose a lot of weight and lose a lot of body fat, but a lot of it was around the midsection, the abdominal section, which is, of course, what most of us are looking to try and do. So it's super exciting.
Not just that, isn't it? Some of it's around your actual organs.
Yeah.
Right?
Yeah.
I was listening to that the other day, how just so people understand, like a lot of times you have your standard fat that, you know, people think about your belly or something like that, the fat under your arms, but then your organs actually collect fat. So like, you know, a lot of them, the most common one would be like fatty liver disease, but basically all your organs can get fat surrounding the actual tissues. And also your tendons can as well. They get fatty infiltration of the tendons, which we'll probably get into with Claire later. But one of those things. So, kind of roll with that one. So they were showing that it had good weight loss, particularly around the midsection.
Well, so it does. All of the different versions seem to cause weight loss, but I mean, essentially, you're not eating food. I mean, outside of anything else, it's the lowest calorie diet you're going to be on typically. So they weren't shocked that people were losing weight. They were a little shocked that people were losing so much belly fat, and in particular, the fat you're talking about, which is that brown fat, the most dangerous one, the ones that hurt our health, that give you heart attacks. That fat in particular was being targeted and being reduced, and that's super exciting. And in a lot of these studies, well, I mean, there's a lot of excitement around it because there seems to be a lot of promise, but there's some question marks too, not the least of which is it's dangerous. Like if people have killed themselves doing this, doctors have accidentally killed patients doing these full fasts and go more than a couple days, where they'll do a water fast for more than 3 days. And as soon as you go past 48 hours on a water fast, you really increase the likelihood of having a significant negative side effect. And not the least of which is wearing your heart tissue out and all kinds of stuff. And even though these have been done, some of them as high as, obviously that 300-day one, but there was one done in Army Rangers, which was like nearly 90 days for a group of 16 Army Rangers. So they have done this, but always under very strict observations by doctors. Anybody trying this at home can seriously hurt themselves. But with that, the next question becomes, is intermittent fasting or fasting superior to simply calorie reduction for body fat or weight loss? And at this point in time, it actually doesn't seem like it is. In fact, there was some early studies in humans that showed that intermittent fasting was causing more body fat loss, but they were using a really poor system to test it. And every time they put the calorie restriction group, just dropping calories from 400 to 500 calories less than your normal to lose weight, versus the intermittent fasting going back and forth between eating, the weight loss was exactly the same for the most part. Body fat levels seem to be back to exactly the same. And all the hormone statistics that we typically look like, from LDL, good cholesterol, blood pressure, all seem to be about the same. So that's an interesting finding, and a little bit of a sad finding that it wasn't having more impact. And the longest study that went for a full year saw zero impact on both body fat and weight when they tested it with the good DEXA scans and really fancy machines.
Yeah, Kirk, I wonder, is there something about changing a person's metabolism, their ability to break down calories, and that sort of thing, or is there some blood glucose component? Because the most interesting thing that I've seen, and I've had a recent weight loss and with the help of a product, and what I think was so successful about it was that it regulated blood glucose. So all of a sudden I was not hungry, and that's super rare. So before this product, I would have, intermittent fasting, go times without eating, no way. And then all of a sudden I kind of fell into intermittent fasting because I wasn't hungry. And I'll tell you, I mean, right. I dropped weight that I really didn't even have to lose at that point. So I wonder kind of your take on that, how it shifts your metabolism.
Well, so that's what makes fasting so interesting, because there's a lot of facets to it. One of them is the hunger component. because we tend to go, when we do fasting, by definition, we end up using ketone bodies or types of ketosis, types of fat, and that reduces appetite. It has a satiety effect. And so along with that, they did this study where they were testing whether or not intermittent fasting, going a 1 day on, the 1 day on, 1 day off, would cause people to overeat. So they do this in animals. So if you feed a mouse 1 day and then don't feed it the next day, it'll overeat for 2 days worth when you get allowed to go back. But for humans, it doesn't seem to happen. In fact, you have about, usually in the average of about 20% more calories are eaten on the day that you go back, but that's still an 80% drop from over 2 days. So there seems to be some significant effect on dampening hunger levels that comes along with some sort of starvation, some sort of not intermittent fasting. And one theory behind that is that human beings were probably fasting most of our history. It would be very unusual for human beings, before current times, and definitely before modern agriculture, even with that you would have had readily supply of food all the time, anytime you wanted it. The chances of even getting 3 meals a day were probably pretty slim for most people most of the time. So it's probably not unusual for people to go in our history to go a few days without eating, or even 1 time a day, stuff like that.
Yeah, so I think one thing we have to focus on, and Kirk, you did a really good job bringing it in, which type of fasting we're talking about at a given time, because I think there's a lot of wiggle room right there. So Kirk was talking about the day on, day off. So Claire, I have a question. Which, with your success, which fast have you been doing? What has been the time range?
So what and this may be something that Kirk can add in too. So, what we're all ingrained in growing up and understanding any little bit of nutrition is breakfast is the most important meal of the day. Now that may be absolute crap now, but I have that kind of stuck in the back of my head. And so in this time where I all of a sudden was not super hungry, and even in the morning, I was like, man, I was forcing myself to eat. I would make eggs. I would, try to get some protein in. And I found that those mornings, I would eat more throughout the day. I was just, I don't know what it was about that. So one morning I just thought, I'm not even hungry. I'm just going to go without it. And at this time I was working outside of the house. And so it wasn't until about 11:30 that I could actually eat. So now I was still having coffee and water throughout the morning, but not until 11:30 was I actually eating. And then in our house, we just kind of closed down shop, after 7:30, we're not eating. And so I was sort of doing it inadvertently. And I mean, I felt great. And I was less hungry throughout the day, and I was like, this is crazy, so, I mean, there is definitely something to it. And
yeah, so one thing with the skipping, I think one of the big things about intermittent fasting, particularly there's different hour breakdowns, but basically the 16-hour fast is the most common, I think. One of the big things with that is you have to be very, for our listeners, you have to be very precise. Like Claire said, at 11, she would eat, right? So sometimes with me, I would go with the intermittent fasting thing, and I would probably go more than 16 hours, but then I would get busy. I'd see a patient during lunch. All of a sudden, I'm not actually eating my meal until 1 o'clock, 1:30. And then what ends up happening is you get at risk for backloading, where you didn't eat during that time, and then once you're finally eating, you're really hungry. So you end up eating too much at night if that's the case. But if you're really good about it and you do that 11 o'clock meal, I think it's really good. And I think that's one of the things that makes, Kirk, you were talking about the success of fasting and the different types, how difficult, for instance, the fasting mimicking diet is. I think the intermittent fast where you skip breakfast and kind of have that 11 o'clock meal is probably pretty attainable for the average human.
Oh, I agree. Well, one of the things I really like is that in America, we kind of grew up with the back in the 90s and early 2000s, the bodybuilder concept, right? Eat 6 meals a day to boost your metabolism. And that was a big thing. And along with many other things, there was a concept of you should eat at any time anybody's hungry all the time. And I think that may have fed into behavior patterns with children and adults, where any little hunger, you just automatically ate something, tamp it down. And so your body was that
you'd say little meals throughout the day. That was like kind of the
right. It just and that was a wonderful theory, and it works in mice. It just doesn't work in humans.
Right.
So That's the issue with it. But there's nothing wrong with that. I know people who eat that often who are lean, but the problem I see for normal people is when we are snacking, we're typically snacking on junk. We're not snacking on good stuff. And the constant eating is probably driving hormones that are appetite regulating hormones in the wrong direction. And when you close that gap down, it seems to be that that flips on it. And so you have more suppressing appetite hormones that are coming out, and you're having less issues with this. So I think that that's probably right. I'm doing one right now, a fast, and I'm witnessing it myself. So I think that that's probably likely to happen for most people.
So one more thing.
And he's in a really good mood, everyone.
I'm past the hanger stage.
The one thing I wanted to mention with that too about the eating little meals throughout the day, and there's nothing wrong with eating small meals throughout different times. But one of the things that they're also talking about a lot recently is also like time restricted eating, which I think is one of the things that intermittent fasting touches on, where the theory is that your liver enzymes only have a set amount of time where they're particularly efficient, I guess would be the terminology. So as soon as you have that first meal of the day, your liver and your pancreas, everybody has to sit there and secrete enzymes to sit there, help you digest the food. So if you have your first breakfast at 6 o'clock a.m. and then, you want to have your little, you don't end eating until your, chips, spicy chips at 9 o'clock at night, that's a long period of time that you've been eating, and those liver enzymes have actually lost their productivity is kind of the layman's way of describing that. So the intermittent fast allows you and they say, I've seen some disagreements. I've seen people talk about coffee, how it stimulates those enzymes. Like if you listen to some of the Rhonda Patrick stuff, I really don't think it stimulates them to the way where it's an actual problem, like an actual meal, right? You have your
Right.
coffee in the morning, like, okay. But when you have that actual meal at 11 o'clock or you have that food, that's, you're sitting there and you're still restricted to a pretty specific time.
Right.
So I think that's one of the benefits of intermittent fasting, right? You're having little meal. You could be having as many calories or as many little meals as you want, but it's between the time of 11 to 7 or something like that, 11 to 6, 11 to 7, rather than 6 a.m. to 9 p.m.
I will tell you too. Oh, sorry.
Go ahead.
I was going to say that, from what I have talked to with friends who have done intermittent fasting really successfully is, and this was something that was always so hard for me when it came to any sort of diet, it's all about either you're counting points or you're counting calories or you're looking at every single thing that goes in your mouth. And so for people who are food obsessed, and I was one of those, and all of a sudden now you're making me more food obsessed. I have to think more about it. That's not successful for me. And so I have found that that's what a lot of friends have said. That's really kind of cool about it is like, I just, if I can just convince myself not to eat one day, then I don't have to count out. I don't have to do anything the next day, and I'm just less hungry. And so I think that is kind of one benefit of these fasting things is you take the pressure off of dieting,
Oh, I agree. That's one of the reasons I think that it may be a very positive swing for people, almost pushing it back against the constant grazing eating we were doing before, to do some appetite control. And for what you said, Claire, most people's issues when it comes to diet, it can be just incredibly frustrating. And the simplicity of just either one day on, one day off, or holding it to 8 hours in the day that I eat, or even this one guy, he did what he called the warrior diet, which he just didn't eat all day long. He just had a big old meal for dinner. I think there's some benefits for that. The arguments that I jumped into is how much better is it? Because that's where people start saying, well, there is going to be some hormonal changes and you're going to get more body fat loss and you're going to get better health. And some of that is based off of the calorie restriction research. And that's where fasting from science essentially has its roots. We know calorie restriction has huge benefits for longevity and blood pressure and all this other stuff. So the question is, can you get those benefits without having to be calorie restricted? Because it's sort of miserable. Like you're cold, hungry, you lose libido. Like it's just a miserable way to live for anybody. And they did that big giant study for 2 years. Those scientists went in a biosphere for 2 years. They came out very healthy and looked like just terrible, miserable people. And a researcher the first guy who talked about it, he's like, I'm glad we did this. there's got to be a better way to do this. So it's not that this stuff isn't exciting, but we're all trying to live lives too. We want it to be terrible. So that's where some of this, where the excitement, because it's very powerful. And some things that we talk about in nutrition, they work or they seem to work, but they're not all that powerful. It may be the difference in a couple pounds per year of weight loss, or dropping your chances of cancer by 1% or something like that. So that's not really exciting to most people. But when you see like the guy studying longevity, when he did his research on individuals, he put them through his fasting mimicking diet. He saw effects after 3 rounds of this that dropped blood pressure rates to normal levels. He reduced IGF-1 levels by over 24%. For everybody, that's one of the markers we look at for cancer and that sort of stuff. C-reactive protein had a significant drop. All these things had huge drops, and that's one of the reasons that he pushed it onto cancer patients. And so then did a study on cancer patients, and when the cancer patients did his fasting diet prior to their chemotherapy, more of those had better remission rates, longer longevity after it. So there's an exciting theory that this might be useful. And it seems that we're playing around with this a little bit. Which version is usual? How much more can it be usual? And how do we do it safely? Because again, if you're going to fast at all, if it's more than a day, you are taking a bigger risk with your life. And here's a weird study. They had a study come out where they were testing fasting, complete water fasting versus very low calorie food fasting. So in one version, when you went into starvation, your body initially starts eating up protein tissue instead of fat tissue. Now, after about 3 weeks of this, it goes to almost a pound a day of just straight fat. But between now and then, you're losing a lot of muscle, and dangerous muscle. But if you eat just a little bit of calories, just a little bit, it turns out that the majority of weight you lose on these types of fasting is almost all fat, which is super exciting.
That's awesome.
One of the things on safety I want to talk about, particularly, I think it's more common with the intermittent fasting, but it's also present. And I think it would be a good chance to transition to the longer fast after this. But with the intermittent fast, we talk about, like, if you're skipping breakfast or working out at 11 o'clock, a lot of times people are working out when they're in a fasting state, which you can do, but you do need to be careful because your blood sugar can be pretty low, something like that. One of the areas is also, you will be burning fat more effectively, but you will also be burning muscle, because a lot of times, so the way it works is, realistically, you work out, your body's going to use glycogen, which you break down and then that into glucose, and then that's your primary energy, which carbohydrates are great for a workout, or high glycemic carbohydrates. But what happens, you're not going to have that glycogen as much, or you're going to get through it pretty quickly. So you're going to start using fat and amino acids. So I would recommend just being smart, like maybe testing out a really light workout if you're going to do that, if you're going to work out in a fasting state. Also, one of the supplements that some people recommend, I haven't seen how valid it is because fasting is so new, is branched chain amino acids. Mm-hmm. Utilizing that if you're planning on being working out in a fasting state. But so we've done a lot on intermittent fasting, and Kirk, I know you've mentioned like the fasting mimicking diet. Can you clarify a little bit more as to what that actually is?
Well, I think this will be, Claire will be able to help me with this because she knows more about inflammation than I do. But essentially, the fasting mimicking diet was developed by this researcher who's the sort of lead in longevity in the world. And what it is 5 days of about an 800 calorie diet that's low in protein and high in complex carbohydrates, mostly vegetables, and healthy fats like nuts and seeds. And he puts you on this with a couple other supplements to make sure that you're safely through. And at the end of the 5 days, you transition to a low calorie diet and then back to your normal healthy diet. Now, he's used that with the hopes that it can cause a reduction of inflammation markers, in particular IGF-1, but other ones as well. And he's shown that effect. That has been shown in studies in humans. So that's the exciting thing, that this has worked. But again, I think that's one of the more promising things is in his theory, what's going on is inflammation is going down because the organs are actually starting to heal themselves. They're starting to shrink. They're going into a protective mode, and that is causing inflammation to be reduced in the long run. But again, how that works in inflammation. Maybe Claire, you can kind of clarify some of that stuff for me.
Well, that I would even say is over my head, but I do, the important thing when we talk about inflammation is it's sort of become the buzzword of any major diagnosis or illness or anything that we're seeing out there. The basis is inflammation and stress in the body, which translates into inflammation, and excess sugar in the body, which translates into inflammation. So inflammation is being found as sort of the root of these really horrible, traumatic diseases. And so I think everyone across the board, whether, from a wellness perspective, a movement science perspective, nutrition perspective, everyone is tackling this. How do we reduce inflammation? And that creates a healthier lifespan, less disease, people feel better, they want to move, all of that kind of stuff. So
yeah, I had a patient where we were waiting because I wanted she had been lingering a little bit. It had been a couple months after a car accident, and I was referring her to an ortho for a dose pack or something like that. And there was some issues with the referral, and we ended up just being like kind of having a conversation. And she ended up just doing a 24-hour fast that I kind of recommended, and she felt significantly better the next day because she gets clean and stuff like that. So yeah, that's one of the big benefits of fasting is how it actually is anti-inflammatory. And I wonder if a lot of it is due to the glucose. How you're probably gonna have less blood sugar and stuff like that while you're in the fast, and then somehow your gut bacteria will probably play a role in that. There's so many mechanisms behind all that. So.
Well, and I think too that, what we have to understand, and this is what I try to talk to patients about, is inflammation is a good part of our healing process. So our body creates an inflammatory process to heal. Okay. So the two problems where inflammation becomes counterproductive is when it's there for too long. So we can talk specifically about an injury, an elbow tendonitis, Kirk, or something like that, where all of a sudden, our good inflammatory, that part of the healing process that started gets stuck. And all of a sudden you've got this acidic, highly acidic, charged, fluid that's just sitting in your tissues, just wreaking havoc and eating away at things and creating even more of an alarm system that goes off. So your brain keeps saying, okay, we've got to keep going here. So that's, one side where inflammation is not so good. The other is, and we're starting to understand more and more about an autoimmune disease and what our body does. And all of a sudden it mounts a major inflammatory response when one is not necessarily warranted. And so there's a lot of different, diagnoses that fall under that autoimmune category. But when it's sort of this global inflammatory, thing that occurs where your brain is thinking, I got to fight something off, but there's nothing really there to fight off, or whatever needed to be, healed has kind of passed through that phase, yet the inflammation feels like it needs to stick around,
Yeah, by the way, one of the markers that Kirk was talking about earlier was CRP, or C-reactive protein, is actually a big measurement of inflammation. So when he was saying that fasting actually drops C-reactive protein during testing, that's actually to show that it's decreasing inflammation, which is really cool. And it decreased that global inflammation. Like when somebody's pro-inflammatory, the most common that people think about, not most common, but one of the very common ones people talk about, rheumatoid arthritis, Crohn's disease, irritable bowel. And a lot of the time, I think a lot of the world's mysteries right now, or, because people talk about these diseases like they know the exact causes, but they don't. A lot of the time people are thinking they're pro-inflammatory, like fibromyalgia and a lot of these different conditions. So like when you start noticing pain, like traveling around your body, stuff like that. But we'll probably talk about that as we go. But yes, what are some other ways we can drop inflammation? Kirk, is there any dietary stuff that you...
Anti-inflammatory diets are simply high antioxidant diets. That's what it's been there for years. Usually the issue is multifaceted, right? The biggest problem, why are we so inflamed if it's due to nutrition, is because we don't eat any fruits and vegetables. We drink a lot of junk. We eat a lot of junk food. We eat too much. Having excessive body weight can cause it. simply getting a healthier diet in your body, more of what I call power plants, anti-inflammatory foods, or fruits and vegetables, beans and legumes, nuts and seeds, and whole grains, as long as you don't have an allergy to those. If those are the ones that on us, the inflammatory index scales are the highest and best ones. So lowering sugar, lowering junk food, lowering highly processed foods in general and highly processed meats in general. All of those are pro-inflammatory foods, and just stuff that we all kind of know. A lot of just whole, real foods, more plants than animal products, and generally as close to nature as you can get. If your grandmother wasn't eating it, it probably is going to be inflammatory. If she was, it was probably
like grandma's pie, right? Because
that's right.
Grandma's always make the best pie. It's pretty
Well,
important.
and you know, it's also important for patients to understand that, or people to understand that everybody's makeup is a little bit different. So, you know, we look at people who've got gluten allergies or gluten sensitivities, milk allergies, you know, lactose intolerance, people that have issues with nightshades, onions, garlics, you know, stuff like that. And so what I tell patients is, and this is really kind of across the board in terms of pain or just understanding your body and what your body is doing at any given point, is being mindful of it. So if you start recognizing, you know, man, every time I have something with tomatoes or you know, tomato sauce, I feel icky. I wake up icky the next day, you know, or soy sauce or what, you know, whatever it is, you can start recognizing in yourself the things that are a little bit more pro-inflammatory to you, and that's going to be kind of different across the board. And that's the struggle with diets in general, or with specific you know, inflammatory type diets, is there's no right, you know, exact ticket, because you've got to know and understand your body a little bit better, and know that, man, every time I eat this is what happens, and I don't feel good, or I wake up and my knees are achy, or, you know, whatnot.
Yeah, there's and they're starting to come out with a lot of the foods that are pretty pro-inflammatory, but that's why like a lot of people are starting to pay attention to this, and there's a lot of diets resolved around it, like the elimination diet and stuff like that. One of the big ones is the FODMAP. So a lot of times I think they get mixed with gluten too, where the low FODMAP diet has a really some pretty strong research coming out for irritable bowel syndrome, which in my opinion just basically means somebody's having bowel issues. They don't know why. But low FODMAP diet. But Kirk, what do you think about the elimination diet? Have you?
Well, I don't know. Elimination diets in general are diets that are very low inflammatory. They're low allergenic diets. So when I learned about this in medical nutrition therapy in school, basically you're putting people on with like a rice and lamb diet. Well, all these foods that are known to be low on the inflammation, low on allergy list, and it's kind of miserable. People will start this for a couple of weeks, and they'll introduce one food at a time and see how their body reacts to it. So that's kind of an extreme thing. I'm not sure that's the same diet you're talking about. I may not be aware of what that elimination diet
There's a lot of different ones, but I think basically the premise is they remove a lot of the top pro-inflammatory foods. Like in like kind of an individualistic randomized control trial, like they're going to remove a lot of like there's tree nuts, MSG, milk or dairy, gluten or FODMAPs. Like it kind of goes through, but really my interpretation of it, and the reason that I find it to be interesting is just because I like to look at, all right, what are the most common pro-inflammatory foods? What are the things that people are most sensitive to, you know, gluten being one, or the FODMAPs, or as he said, like a lot of people can be milk, like have a sensitivity to milk, but it still goes back to that, like being kind of mindful over your own situation.
Right.
Yeah, and the understanding too that when you try one of these things, and it's hard. I mean, we live in South Louisiana, like where food is good, you know, it tastes really good. And so the issue becomes, you know, being careful with a full elimination like that, because all of a sudden you're going to start changing the chemical makeup of what your body can really tolerate. So the risk in this is, number one, a major healing crisis is what we call it. A healing crisis occurs when you eliminate sugar and all this crap that's been in your body. You have withdrawals, you have a lot of pain, you get a massive inflammatory reaction because your body's like sensing something major is shifting and happening. And then, you know, you're adding back, and the thought sometimes is, you know, we add everything back in, and all of a sudden we weren't feeling so bad every time we ate dairy, but now all of a sudden I can't, you know. And so there's some thought there as well.
Yeah, there's probably totally a kind of I'm trying to think of the word to describe it. There's totally almost I expect it, therefore it happens, kind of like a feed forward, right?
Yeah.
Kind of a feed forward situation. But yeah, so let's kind of chat about what happened. So we talked a lot about pro-inflammatory situations. What about that, Claire? This is going to be for you. What about that situation where somebody rolls their ankles? Do you think they need to be going hardcore anti-inflammatory, right, when they roll their ankle, or?
Right. When I start talking, and I'm not afraid to talk to patients about diet, about nutrition, about mental health. I tell them this is not my specialty, but when it comes specifically to understanding our pain experience and how our pain can be amplified or lessened by adjusting some certain things, I can definitely talk to patients about that. And so when it comes to a really acute injury, I won't go straight there, but of course I'll talk to them about the stuff that gives you some immediate inflammatory control, some compression, ice, massaging, milking that thing, getting some, some good, movement of fluid and good oxygenated and nutritious blood kind of coming through there and filtering out any of the gunky stuff. But it's more along the lines of the chronic, the more chronic diseases, and it doesn't even have to be chronic inflammatory diseases, although that's a definite that I'm going to talk to about, for them, but somebody who's like, the bone on bone and just about every joint and stuff like that, for them to recognize, or even people who don't have those diagnoses, but they come, they're like, I'm, 40 years old and I wake up and I'm achy my first 10 steps. Like I shouldn't be achy, and this otherwise healthy individual. And that's when I'm going to kind of start just throwing it out there and just say, look, I mean, it matters what we put in our body, and so I don't know if that answers everything, but.
Yeah, no, I absolutely. So it's a lot of the times, these are the kind of conversations we have with more of a chronic situation pertaining to pain. A lot of the time where it's a situation where the person clearly has an inflammatory or pro-inflammatory situation. So I think what I was kind of wondering is, like, when it comes to an acute injury, we're not necessarily trying to be too intensely anti-inflammatory a lot of the time, versus a chronic pain situation. It's a little bit different. So one of the things we're going to talk about is, like, when you look at inflammation, I think one of the big things that we have to address is how inflammation and pain work together. And so one of those avenues, when you look at inflammation, you look at pain. I think Claire talked a lot about the acute situation versus the pro-inflammatory situation. But I kind of wanted to transition a little bit. So what are some other avenues that pain can occur? And like when you're sitting there doing your evaluation on patients, what are the other avenues other than just inflammation, or just like somebody that didn't just twist their ankle, the pain's a little bit more chronic, something like that? What are the other avenues that you're looking at with those kind of patients?
Yeah, that's a great question. And pain, pain encompasses our entire experience of my brain is perceiving something as threatening, and I tell that to patient, and pain is as simple and as complicated as that statement, where our brain is recognizing, okay, have I been here before? Is this potentially dangerous? Do I need to make some adjustment or move? And so, but pain across the board has different facets. So you can have a pain experience because of an inflammatory reaction. Yeah. And the reason being is we've got a chemical acidic, fluid that's sitting in our tissue, and we've got those chemoreceptors in that tissue sending messages to the brain. God, something's really going on here. And then the brain saying, yeah, that's, there's an injury there. It's healing. And so there's different. And so then you have a pain associated with a myofascial trigger point, or pain associated with a neurogenic, tissue, or anything like that. So pain is not always equaling inflammation. And this is where patients come in and say, the Advil doesn't help, or the Motrin, or the, Mobic, or whatever, has been referred to them, doesn't help. Or, or they'll come in and say, they put me on a muscle relaxer and it hasn't helped. Well, in my head, I'm kind of deducing, okay, well, a muscle relaxer typically would help when someone's got a global central nervous system, kind of that protective, response happening. So maybe there's something else there. Or if that inflammation is a major player, then somebody takes Advil or some sort of anti-inflammatory, then they're going to feel better, at least to some degree, and I always say, if they don't feel better, if they don't feel fully better, there's probably several different facets that are happening all in that area. A perfect example is a simple knee osteoarthritis. There is pain because there's inflammation sitting in the joint. There's also pain because there's the fluid, the extra inflammation is taking up space in the joint, and it's creating a reflexive inhibition of the quad, or there's a trigger point there that's also creating some pain. So all of those things, kind of have to be addressed when you're looking at the total picture, because it's not as simple as, okay, I'm just going to, get the inflammation out of there, and all of a sudden that person's going to feel better. They may have been walking in a funky, movement pattern for years and years. And yeah, you eliminated an inflammatory situation, but there's still a lot of other things that can create an experience of pain.
Yeah, to clarify, the knee osteoarthritis is kind of a situation where you get kind of that inside of your knee because it's the most weight bearing. As we age, that area tends to kind of, I guess the term would be age. Nowadays, yeah, people like to say degenerate or something like that. But, I always like to make the joke, well, if somebody gets a wrinkle, you don't say the degenerative face disease. So if their knee has some arthritis in it, it's perfectly okay. But it can lead to pain. Right. And one of the things that I also notice, other than that arthritis or degeneration in there that can lead to that inflammation, a lot of times that kind of patient, they almost have a fear avoidance of using the knee, which then leads to them not using it. So I know we've talked a lot about that, privately. So I was wondering what your thoughts on that, about like kind of more of the fear avoidance type situation with some of them.
Yeah, I think there are a lot of factors that affect someone's pain experience.
Yeah.
And fear and misinformation, or lack of true knowledge and understanding about why I'm hurting, I think are the biggest players. And so, the perfect example is people go and get on WebMD and put their symptoms in, and they have a little headache, and all of a sudden, they have a brain tumor, and all of a sudden that pain is much more intense than it was back then. There's actually I always cite this study when I'm presenting on pain as an example of this, but there was a study done with elderly patients who were severe osteoarthritis in the hip, bone on bone, had been, when they do these studies, you have all this inclusion criteria. So these people were pretty much the same across the board. They had one surgeon that was doing all of these surgeries, but they divided this group into two. In one group, they had a one-on-one session with the physician. The physician talked to them about what the surgery was like and what they were going to do. He handed them the prosthesis and said, "Oh, doesn't that feel great? These people have been bone on bone, just, and so the idea of, oh my God, that smooth joint surface, that's incredible. But really, kind of calm the central nervous system stress response to the anticipation of what was going to come. And then the other group, they put in a room and they put on a video of a total hip replacement, which, if you guys know anything about, if you've ever been in one of these, I mean, it's barbaric. There's sawing and hammering and stuff. So in the post-operative, they measured post-operative pain in these two groups, and it was significantly lower in that first group, who had an idea of what was to expect, but not in a sense of a fear, thing. And so, I mean, fear plays a huge role in this. And when we talk about loss of job, loss of wage, loss of, what we love about, life, and can't do what I love, I mean, that creates an overarching weight, on top of what you're already feeling, and it creates a more intense pain experience. And so that, the mental and emotional aspect of pain, I tell patients, your brain doesn't recognize the difference between a physical stressor and a mental and emotional stressor. The response is the same with that sympathetic protective response. So if that stressor's there, and no one has ever sat down with these people and really just, express, this is why you're hurting. This is what this is what your body does in response to an injury or whatnot, and give them all those tools, then whatever they're feeling is just going to get more and more intense. Oh my God, my aunt had a disc, bulge, and she was disabled and she couldn't do what, and all of this stuff. And all of a sudden you've diagnosed yourself with something horrific, and you can't get out of that,
Yeah, and I think a lot of that pain is also a fear of tissue damage. So
Yeah.
do you ever find, you feel like, I mean, this is going to be, I'm just throwing a softball up for you right now. What do you think, if I were to say, do you feel like pain, the amount of pain someone's in, actually correlates to tissue damage?
Absolutely not. And in an acute situation, we expect that that's the case. There's this beautiful picture of the curve of acute pain versus persistent pain, where tissue damage and healing, that pain follows that curve. But the problem is that that's unrealistic. That's in a perfect scenario where I don't have any preconceived beliefs or notions. I don't have that aunt with the disc bulge that's on disability. I don't have all these other things. That's a perfect world that pain experience follows that tissue damage and healing. But what we see more often than not is we go into this kind of central sensitization, where all of a sudden the pain experience is more of a central nervous system mediated thing, rather than it equates to some damage in the tissue. And what's really interesting, you can, when we look at persistent pain, so our brain can create an experience of pain that's so significant with absolutely no tissue damage or with no tissue whatsoever. So residual limb pain, or a fully healed, these are the patients that come in with severe pain and their images look perfect, and their physician, they've had maybe a surgery. Everything we did looks great. I mean, this should be fine, but why are they still in pain? And then on the flip side, you have a situation like a soldier in battle who steps on a bomb and gets half a leg blown off, but is still able to make it to a safe base. Because in that moment, instead of your brain saying, whew, that hurts, and I'm going to drop you to the ground and have you writhe in pain, it was more important in that moment for you to get to safety. And so, the brain is in control of everything. And that's it's sometimes a hard pill to swallow, because people have been so offended by this idea of it's all in your head, and it isn't all in your head, but the overarching, and the brain is in the ultimate control of it's going to have the final say on what your experience is.
Yeah, I always tell patients that your body learns pain.
Yeah.
Like, as you go, your body will actually learn that pain. So if you're experiencing, like, if every time for 3 months, every time you do this, it hurts, where you raise your shoulder and it hurts, well, you start to expect it to hurt, and then you stop doing it, right? You stop doing it very quickly. And then what happens though is you expect it to hurt every time you do it. So a lot of rehab is actually guided towards teaching you that you can actually do it and you're not doing more tissue damage.
Yeah.
And I think that's one of the issues with our current model of healthcare, where somebody hurts, we take a picture of everything.
Yeah.
And so I think that's one of the big issues. So I'd actually like to ask you about that. So like, I think we both read a lot of the research on imaging, but I was wondering if you could summarize for people out there, like all the imaging studies on asymptomatic MRIs and stuff like that.
Yeah. I mean, I think what we have always tell patients, an image can show so much that has absolutely nothing to do with what your pain, what your pain you're having right now. And not to mention, when we're taking an image, when a patient is really in an acute, stressful situation, meaning these huge dominant forceful muscles are all tight and they're in that fight or flight, ready to protect mode. If I take an image of a low back in a patient whose hip flexors, their iliopsoas, their QL, everything's super tight, it's going to look scrunched, things are going to bulge where they shouldn't, but, what Chris was saying is all of these images or all of these studies are coming out where they are testing and taking images of healthy, asymptomatic, zero pain whatsoever individuals in a certain age range, usually when we talk about like low disc issue, so age about 20 to 40. And it's over 80% of these people that are having bulges and herniations and have absolutely no symptoms whatsoever. And so there's no real correlation there. And I think there's a huge fear surrounding a disc, and this idea that this disc can just, burst out and fly out in every direction. Or I have patients that are like in their 70s and they're still talking about a disc bulge. And I'm like, at this point, your discs are nice and solid and right. There ain't nothing liquidy bulging out of that, And so that understanding that the image can show quite a bit that has nothing to do with actually what's going on. And I like what you said too about this sort of a fear avoidance of moving in a certain pattern, because every time I do that, it hurts. And what I try to tell patients, and what we work on a little bit, is like a graded motor, kind of exposure, in the sense that, okay, you say that every time you bend down, there's a sharp, something in your low back. Well, I'll tell you that sharp something in your low back is your brain setting off a little alarm saying, last time we did this, there was some issues. Okay. So I'm just going to warn you. I'm just warning you, this is not saying that something's ripping, something's tearing, something's bulging, but it's just simply a warning. And immediately when we go into that like exposure, that graded exposure to certain movement patterns in a nice controlled environment, that 5 to 10 rep mark, they're like, I don't even feel it anymore, and did you get rid of my disc bulge? And I'm like, nope, I didn't do that, And so I think the true thing is the more confidence we have as clinicians in understanding pain, and the more we can deliver that to a person who does not have my same background and understanding of neuroscience, that's the delivery. That's where we lower that fear, or we stop being clinicians that say you have the back of an 80-year-old, or ooh, this is horrible, as you're working on something, ooh, this is, wow, this is so bad, because that amplifies that pain fear response in patients.
Yeah, absolutely. Absolutely. If you sit there, I always make the joke though, if like somebody's never had back pain in their life, and then you sit there and you pull them into a room, take an MRI and say, oh man, that looks terrible. You got a bad back, or you got degenerative disc disease. Give it a year, that person's going to have chronic pain. Like I said, when
100%.
Most bouts of low back pain tend to diminish within 6 to 12 weeks. Now, the issue then is they tend to come back because most people sit there, they wait for the pain to calm down, and they don't do necessary graded exposure or loading, or they go back to the same movements that might have aggravated the pain.
So, Chris, I want to take a guess, because I'm completely guessing here, but I would guess that somebody has done research that says that people who are more sedentary generally have more levels of inflammation, and that it's somehow correlated to pain. Am I right in that guess?
Yeah, I would say so. Most of the time, people that are sedentary, one of the big things, and we kind of talked about this last time, is the importance of just movement in general. So if somebody's not moving, like, even I think the simplest example of what movement helps do, especially pertaining to inflammation, is like, we were talking about, Claire was talking about the, like how some of that inflammation could get caught under the tissue, causing that nervous system response, right? Where the nervous system is getting this negative signal constantly, like it's like a baby screaming into your brain. And your brain's like, stop doing that. It stops doing it, it actually crutches it. When a lot of the time, if there's actually inflammation in there, the goal is actually to get movement, right? You need to movement. And of course, depending on the tissue, but your muscles actually act like, a really easy example is a lot of times cardiologists or a lot of people say that your legs are your second heart. Because what happens is your legs, the muscles contracting around those blood vessels actually helps flush everything out. And so some people would say that, like, rehab, I don't 100% agree with these guys, but like, they'll just say like, just keeping moving is the most important thing when somebody's in pain. Now, I think there's times where there's a movement that you're sensitive to during the acute stage where you need to let the nervous system calm down, right? Because when she was talking about that central sensitization, or where your body's just locking down, sometimes you need to let the body calm down. In the office, I always say it's like if somebody has a really angry wife because they put the shoes in the kitchen, and if the first thing you got to do, you can give her flowers, you can give her, you know, whatever you want, you got to get the shoes out of the kitchen, right?
That is a good point. That is a very good point, sir.
Yeah, but that's during the acute stage, right? Then what happens though is during that stage, people create that fear avoidance where it's like, okay, you know, every time they come close to putting the shoes in the kitchen, they get so scared of it, when maybe first off, that your body might not even be sensitive to that anymore. That was an issue from 15 years ago where the guy's sitting there saying like, oh yeah, I've got that L5 disc back from 1991. And I'm just like, all right, I don't think that's the variable in the pain right now. You know, and you get into those asymptomatic studies where you find those disc bulges, like people could have had the disc bulge before the MRI, and that's not the reason for the pain. Or you see that a lot with arthritis, right? Like somebody has acute pain and it's blamed on their arthritis, and it's like, well, 2 weeks ago they were fine and they had arthritis. Like arthritis didn't develop overnight. A lot of those are problems. And that just, I mean, I could rant about the imaging stuff where we've had like, you know, they're showing studies on surgeries for knee arthritis that aren't beating placebo. And this isn't a knock on the surgeries at all, because surgeries are necessary a lot of the time. But what's happening is we're finally learning in the past 20 years or so that surgery isn't the first option. We need to take these images in context, and we need to connect them and correlate with them clinically. Like if somebody says like, oh, and by the way, everyone, the discs are like in your spine, you have your different vertebrae. The discs are basically, I mean, I could get flack for saying this, but it's like a really strong, like thick outside of fibrocartilage with a little jelly inside. Everyone would get mad at me for saying that, but and so they can get tearing and stuff like that. The jelly can come out and it can cause nerve irritation, stuff like that. So if you see that with symptoms that match that, and then on the MRI it confirms it, all of a sudden, yes. And then if they're getting loss of function in their leg and stuff like that, okay, we're starting to look at a situation where we might need an ortho, where their foot is dropping, stuff like that, where they're getting caught equina, where they're losing sensation, losing control over bowel and bladder. There's a ton of reasons for surgery, but a lot of times the first line isn't just to jump to surgery. The first line is to try to do some of these things that we've been talking about, where you try to calm things down, strengthen it, educate someone on pain, educate someone how to manage their own pain and stuff like that. And then when all else fails, that's when, and a lot of the best surgeons are rolling with that. They're referring to PT, they're referring to chiropractic. They're saying, hey, go try this first. And then, you know, there's other times where the other day I had a guy whose shoulder, he failed every test I had, and I sent him instantly out for a shoulder eval from an ortho who's probably gonna get surgery. So there's a huge line here, right? But the most important thing is that we don't overreact to the image. Whether it's patient perception or it's, you know, clinician perception. Like if somebody sits there, looks at the spine, it's like, oh my God, that's terrible. Like, oh, your back is terrible. And that patient's gonna be in a lot of trouble.
Yeah, and I'll even say, you know, on top of that, you're exactly right. There are necessary situations when surgery is the thing. And the beautiful thing is that our medical physicians, our surgeons are trained in understanding medicine, and they're trained in understanding surgery. So like when we need that, we've got that covered, you know. But even so, and when it's absolutely necessary, if you first go through a downregulation of the pain experience, decrease inflammation, normalize as much as you can, create a balance back in the system, strengthen, those patients are going to come out and do so much better post-operatively. And what I think we're finding, like you're saying, Chris, is that the physicians now, they want that, man. They want these good outcomes. They want patients to feel good and come back. Nothing, you know, I have a good buddy who's an orthopedist. I mean, nothing is worse than the patient coming back in and saying, I still have pain, you know, and you're looking at the image and you're looking at your surgery and thinking, man, we did everything right. How, you know, and so I think they're getting tired of seeing that. And so it's all good. There is no wrong that can be done. If you have clinician, this is another kind of soapbox of mine, is get a clinician that you know and trust, that's on your team with your primary care doc, with all of your doctors that you trust to say, let's try this first. Or if I try a couple of visits and things seem to be, like you said, Chris, like, no, this is out of my wheelhouse, then I'm sending you straight there. But that's, I think, the hard thing about it is we have a primary care doc, we have a cardiologist, we have a dentist, but we don't have a physical therapist, a chiropractor, a wellness provider that we go to as that primary entry point to say, what do you think of this? And, there's rarely do I find that there's not an opportunity to give someone some great education on pain, controlling some inflammation, just settling whatever acute situation is there, and giving them better outcomes if they do go and get an image. So if I can give you a couple of release techniques to just kind of calm that overly protected hip flexor or QL, well, your image may not look horrific, when you go in to the doctor the next week. So
yeah, absolutely.
Right. So let me jump in and kind of jump on the nutrition bandwagon of what you guys are talking about. It's just the idea that there's so many other factors and issues, and there's so many general problems that sometimes people will look and take an extreme approach to fix a minor problem, or they'll jump to a diet as a magic pill. And a lot of times we'll look at studies. It's one of the questions we always have to ask when we're comparing studies, is if you're looking at a dietary program, whatever it is, whether it's paleo, Mediterranean, intermittent fasting, or anything else, and like, oh, we did this study and it did really well and they lost more weight. Question is, against what? If it was against the standard American diet, everything's going to do really well because it's so bad. So a lot of times that's one of the cautions with taking an extreme diet of any sort, with particularly you should get medical help beforehand, but taking an extreme diet could lead you to problems. For example, fasting. Back in right after World War II, they found that one of the most dangerous times of fasting is when you refeed. So POWs from World War II camps were starved. And then when this happens, they can run low on certain vitamins and minerals, in particular thiamine. And then if you refeed them with food so fast, their thiamine levels can go so low in the help of digesting the food that it causes multi-system organ failure and they die. So it's where banana bags came from, right? Why we have those yellow banana bags to help people who have been starved for so long is these sort of extreme diets, extreme natures can be too far. And none of them should be done without some sort of qualification first, whatever they happen to be. And most of the time, what I've noticed just across the board, whether I was working in corporate wellness or with individuals, is most people aren't athletes or bodybuilders who need extremes or calorie cycling or carb cycling and that. Most of them, if they could get a flat diet going of any sort, probably would see most of their health problems go away and their waistline shrink. The issue is being able to do it consistently. One of the things we're talking about, reducing inflammation, improving health, just by people living healthier, whether it's through intermittent fasting or anything else, that alone may fix a lot of the issues.
Yeah, I'll say the same thing for physical therapy, for physical wellness. Is the key is just movement. And I always say, with restriction, if someone has had a major accident and they're coming to me first, and there's could suspect either a fracture or some instability, movement's not always the answer. We're going to get some protection, but for the most part, 98% of the time, movement is absolutely necessary. And it's just going to it's going to help us. It's going to make us feel better. And one of the things you were talking about, I love the thought that inflammation, when in our system, at rest, inflammation gels up. So if we've got inflammation throughout our system or in certain joints or whatnot, and we are sitting all day, when we go to take that first step, and when we get up in the morning after we've kind of laid down, it's going to take us a second for us to, exactly what you were saying, our muscles all function as little circulatory pumps. So until we kind of get moving and flush that gel out and get things kind of nice and fluid again, it's going to hurt and it's going to be stiff and all of that stuff. So movement is the absolute, the key to just about everything. And I think we always tell patients, I mean, we sit so much more than our human anatomy, our design was ever created to sit. If you look back, you know, they didn't post up sitting on rocks, they squatted, right? They squatted for everything. And so we've done a huge disservice. I mean, people like to say sitting is the new smoking, and I don't necessarily know I would go fully there, but there is a lot of traumatizing things that happen systemically when we sit for so long, when our iliopsoas is so tight, when our viscera in our abdomen is so adhered. I mean, it creates a lot of health issues. So if you're working and you sit all day, get the higher ups to get you a stand up, sit down option, move around throughout the day, stop every 45 minutes, get up, you know, it's necessary.
Movement is medicine. Is what I
yeah.
Movement is medicine. And I think to relate what she was saying that sitting is the new smoking is because a study came out where they said that like people that sit too much, it takes like 7 to 11 years or something like that off your life, just like smoking, which of course those are pretty, you know, like overall observational, like, you know, don't be scared that you're sitting, you're gonna die.
Statisticians are not saying that, right?
Yeah, you gotta. The key is you gotta get moving, and I tell people, you know, everyone argues over a different posture and stuff like that. One's perfect posture. Thing is, if you're sitting all day, if you're at the age of 25, you get a desk job, and you sit at that desk all day, every day for 8 hours, your body is literally going to adapt to that position. But I think we're approaching a little bit over an hour, so let's just Kirk, we'll start with you. Then, do you have any final words for everybody?
When it comes to intermittent fasting or fasting in general, what I'd like to say is the most important thing you do, and what the studies have shown with this, is that you can lose weight quickly on this, and it can be relatively effective. But most long-term studies, more than 6 months, find that people put the weight back on. So while it may be an effective tool, you still have to have the cornerstone of a healthy diet that is long-term for this to work. So the only other thing is, if you're going to try out intermittent fasting, you really should talk to your doctor or a dietitian or somebody else in the field to help you, just because they're slightly more dangerous than other types of diets out there.
Yeah. Awesome. Claire? Final
well, I don't think I undershared at all tonight, but but I will say is just the understanding. And if you're someone who suffers with chronic or persistent pain, and you know, you feel like you're kind of hit a wall with I'm on these medicines, or I get these routine procedures and stuff like that, you know, really kind of look at the total picture of your life, not just nutrition, but, you know, what are the postures that I'm assuming on a daily basis? What's my stress level? What are some things that are creating so much stress that I need to let go of, say no to? Where can I create some space for some mindfulness, meditation, some gentle yoga, anything that's calming to the central nervous system is going to change your experience of pain substantially. That and truly understanding it. And if you need someone to go there with you, just call me up. I'm a stay-at-home mom now, so I'm just talking to a 1-year-old, and she is not interested in pain.
Yeah. No, I think I love the way you're describing everything. I always say it's kind of like I always say visualize your pain cup, right? So all this stuff you throw in, right? A bad diet, all the inflammation, all that stuff. If you know, they're showing so many studies on just like a breakup in high school athletes, stuff like that can lead to injury. All these things. So throw that all into the pain cup. And a lot of times when we get a patient walking in, the pain cup's just overflowing. So I always say, you know, we gotta figure out what is making that pain cup overflow, and then we want to build you a bigger cup. And those are generally the goals, and really looking at stuff. And if somebody's pain cup's overflowing and they get surgery or something like that, you know, all of a sudden that's like giving an alcoholic a new liver, or a smoker, you know, you can't give them a new lung, but if you could, it's really, I mean, it's not breeded for success. So you want to learn how to move. You want to learn how to eat. You want to learn, and honestly, the fasting stuff is so incredible. You want to learn how to fast healthily. All these things are so important for overall wellness. But I think that's our time. So I'd like to thank Claire with Elevate, a wellness studio. She's a badass physical therapist. Pardon my French. Kirk Vidrine with Well Solutions. I really enjoyed talking to you guys today. It was awesome.
Awesome.
Thanks,
Thanks for
Chris.
having me.